money. So Deeksha is going to show us illustrative cases as to how to suspect and diagnose vitelliform degeneration. Yes.
Thank you, ma'am. Thank you very much for this opportunity. I will be talking on relevance of vitelliform lesions in age-related macular degeneration. So as per the current understanding, vitelliform lesions that we know of are either hereditary, or now we also know that they could be acquired form, which are known as the AVLs. The hereditary forms are traditionally, we kind of related with the Best vitelliform dystrophy, usually presents by the second decade of life, the typical egg yolk lesion that is seen. But we also know that there is an adult form of this dystrophy, which is also associated with BEST1 mutations, can be associated with the peripheral RDS mutations, which has a later onset. Apart from that, there are conditions where you may have acquired vitelliform lesions, and some of these conditions include age-related macular degeneration, central serous choroidopathy, ocular inflammations, drugs such as pentosan, and even tractional maculopathies. The clue is to differentiate these two forms so that, as ma'am said, we do not intervene unnecessarily. Why we are clubbing them together? Because they seem to have a common pathway of pathogenesis, which involves either an inherited or an acquired RPE dysfunction and a loss of apposition between the RPE and photoreceptors, which results in impaired phagocytosis and turnover of the photoreceptor outer segments, leading to subretinal, is the key word here, subretinal accumulation of vitelliform material, which has precursors of lipofuscin, melanolipofuscin, and pigment-laden macrophages, which impart common imaging characteristics regardless of the etiology. Let's go over this case. This is a 50-year-old male who presents with diminution of vision in both eyes, slowly progressive over the past 3 years. He has received 2 anti-VEGF injections elsewhere for a diagnosis of a choroidal neovascular membrane. Visual acuity is 6/24 and 6/12, and if you look at the fundus, the macula has symmetrical appearance of yellowish white round to oval lesions in the central macula, surrounding by a layer of hypopigmentation. If you do an OCT, you see that this deposit, as we may call it, lies between the RPE and the photoreceptor layer. There is associated subretinal fluid. Notably, the foveal contour is not disturbed. There is no intraretinal fluid, and also the RPE does not have any sub-RPE components. Similar appearance to a lesser extent is seen in the left eye. The autofluorescence, though not very characteristic as we see it, but yes, it depends on the amount of lipofuscin in this material, will be brighter as we see in the right eye, not so much because of the quantity of the vitelliform material is less in the left eye. If you do a fluorescein angiography, it is going to show that the central lesion is hypofluorescent, and the surroundings may form like a ring of hyperfluorescence. In the late phases, that central ring may show some hyperfluorescence, which often confuses it with the late choroidal, which is known as the occult CNVM. So the angiographic picture may be confusing. So, and similarly in the left eye, we see some late hyperfluorescence coming up from center of the lesion, which may confuse it as an occult CNVM. But if you do an OCTA, this is the NFAS imaging, the deposit is hyperreflective in the outer retina. Also, it is extending into the deeper layers. And if you see the flow, there is actually no flow in the lesion, within the lesion, and also we do not see any choroidal neovascular membrane on the OCT angiography slabs. Similar appearance is there in the left eye, and correspondingly we do not see any choroidal neovascular membrane, and neither is there any flow in this lesion. If you do an EOG, this is normal in this case. So just to differentiate what AMD and AOFD, the vitelliform, adult onset vitelliform dystrophy occurs a little younger than AMD presentation, usually in the 4th to the 6th decade. Patients are generally asymptomatic or may have minimal visual symptoms, generally non-progressive or very slowly progressive. Drusens, which is a hallmark of AMD, are not rarely that often seen in the vitelliform dystrophies, though they may be subtle. Sometimes they may be accompanied by cuticular drusens. So we should not confuse. In 33 to 60% cases, there may be some drusenoid deposit accompanying them. Pigmentary abnormalities are seen both in AMD as well as the vitelliform, though in the vitelliform degeneration, the pigmentation is mostly central and surrounded by a hypopigmented halo. The key on OCT is the subretinal location of this deposit vis-a-vis the sub-RPE location of the hyperreflective material in AMD. Fluid in AMD can be in the subretinal, intraretinal, or the sub-RPE compartment, whereas fluid mostly will be in the subretinal compartment in the vitelliform, and very rarely will you see accompanying intraretinal fluid. EEG can be normal in these cases, and fundus autofluorescence shows a central hyperautofluorescence corresponding to the deposit. In the late stages, there will be irregular RPE loss. This is another one of our patients. Here we see the typical fundus autofluorescence, which is showing a bright hyperautofluorescence corresponding to the vitelliform deposit. And fluorescein angiography, I would like to again reiterate, may be confusing in these cases. The natural course is biphasic. There is a period of growth followed by resorption. The resorption is accompanied by focal loss of the outer retinal layers, mainly getting affected the outer nuclear layer, the ISOS junction, and the external limiting membrane. Thinning or loss of the RPE can be there, and the ISOS junction and external limiting membrane loss generally results in the decline in visual acuity. Choroidal neovascular membranes are in general rare in this disease, and if they do occur, they are mostly the type 1s. But majority of the patients tend to retain reading vision in at least one eye throughout their lives. This is another one of our patients. Now, if you see the typical lesions, subretinal here again, over a course of 5 years, what is happening to the lesions? In between, we see that the pigment migrates into the intraretinal compartment, then gets reabsorbed. Ultimately, there is resorption of the material with loss of the ISOS junction and the external limiting membrane. Whereas in the other eye, we did see migration of the pigment into the intraretinal compartment, but there is absorption, but the outer retinal layers remain preserved, and that is why this patient has good visual acuity in this eye. EOG again is normal. The subretinal fluid in these cases generally is a result of the mechanical displacement between the outer retinal layers and the RPE from pumping of the liquefied lipofuscin, and it happens during the course of the disease when this vitelliform deposit tends to get reabsorbed. We can see this happening in both the eyes. Now the only question is, how do we know when do these patients actually develop a choroidal neovascular membrane? So a split in the retinal pigment epithelium basal lamellar Brooks membrane band means if you start seeing something happening below the RPE and you start seeing intraretinal fluid coming up, that is the time we need to suspect that these patients have developed a choroidal neovascular membrane. So take-home messages are acquired vitelliform lesions occur in a variety of different clinical entities. They share common fluorescein angiography, OCT, and FAF features regardless of the underlying clinical diagnosis. The diagnosis of choroidal neovascularization in the setting of vitelliform lesions using fluorescein angiography can be challenging. So we have to integrate multimodal imaging, and most of the time a combination of an OCT and fundus autofluorescence clinches the diagnosis. If you have OCTA, well, that can add definitely. And this can help refine management and avoid unnecessary interventions and follow-ups in such patients. Thank you.
Thank you very much, DEEKSHA. My question to you would be, when you look at a patient of AMD, clinically, what makes you suspect vitelliform?
Ma'am, if we look at a patient, first we look at the drusen's. A patient of AMD, the hallmark feature which we see are the drusen's. Now, if we see only small drusen's, we are not seeing the intermediate or the large size drusen's. If we see any intermediate or large drusen's and bilateral, then they will fall towards the AMD group. But if the lesions of the drusen's are generally smaller, and you are seeing this yellowish lesion right in the front and on the OCT, which is subretinal in location, then we start thinking, and bilateral, then we start thinking of a vitelliform dystrophy.
So if you are thinking of vitelliform, you will not really go for fluorescein angiography,
yes.
no?
Yes,
it's
absolutely.
better just to do OCT and look at the flow.
Yes.
If there is no flow, it's more likely to be vitelliform, and there is no hurry to inject.
Inject, absolutely.
And as you said, on OCT, the location would be subretinal and not sub-RPE, which would be in AMD. Any questions for Dr. DEEKSHA? Well, thank you. If there are none, thank you, DEEKSHA.
And
any advantage of ICG to differentiate AMD from AOVFT?
Yeah, if you talk of an angiography, ICG does add value because the lesion that you see, the hypoautofluorescence, the hypofluorescent lesion which you see on the fluorescein angiography and the late hyperfluorescence, that is not seen on the ICG angiography. So there will be no leak and no corresponding leak on the ICG. Though ICG is not really required, most of the time an OCT and a fundus autofluorescence is enough. But if you have ICG, then that can add on to your diagnostic capabilities by not showing any choroidal neovascular membrane or leak on the ICG, which is confused on the fluorescein, where you see sometimes a late staining of the lesion, which is confused with the late occult CNVM.
The image that was presented by you.
Can you please speak in the mic?
Your image of the ICG.
No, I have not presented any ICG. That's a fluorescein
ICG
angiography. No, it's a fluorescein angiography on the spectralis.
On spectralis.
Yes, yes.
So I think what Dr. DEEKSHA is saying, the ICG is basically to identify the membranes in AMD. In adult onset vitelliform, ICG is not going to show any features. And if you can look at the membranes either on OCT by looking at the flow within that hyperreflective material or on OCT angio, so probably ICG is not required, but if you do not have OCT angio and you want to confirm whether there is a membrane or not, ICG will help. But ICG will be kind of not show any features in vitelliform. So that way it helps. Any further questions? Thank you, Dr. DEEKSHA.
Thank you, ma'am.